Hello again, guys. Obs Gyne placement, my placement at Royal Bolton Hospital, how I found it, what I found more useful, and top tips in order to make the most of it. So here goes. Let's start off with the community practice, although this was not the order in which I went through my placement, but in essence this is probably how I find it to be of most use. Booking in clinic in the community, that's what I attended. So typically you have your patients an hour and 20 minutes, and the midwife is going to conduct a very detailed history. The history doesn't just entail the actual presenting complaint of any sort, because there is no presenting complaint. This is usually the first appointment that the patient is having after having conceived with the midwife, the first contact. Here what we do is the midwife is going to screen the patient for any sort of risk, be it psychological health, mental health, domestic violence, any risk of embolism, and then there are all the we kind of stratify risk of the likelihood of genetic disorders that the child might develop, so deafness from birth, blindness from birth, and the likes of all these. So this is, and I promise it takes you an hour and 20 minutes. It flies. Now, what was really interesting to hear from the midwife is that they get medical students or otherwise who just want to take a seat in the back and not do anything. It's up to you. It's honestly up to you, because what the patient has to have is your height and weight, therefore calculate the BMI, thus stratifying risk, because this in essence dictates how many scans they have and whether they're at low, moderate or higher risk. But aside from that, this is one of the categories. So BMI, so therefore height, weight, blood pressure, opportunity to get some practice in the blood pressure. Manual one is probably preferable. But then taking bloods, so we've got to take that blood, we've got to take that group and save that bloods as well. So venipuncture, you've got CO monitoring, amongst a few other, and urinalysis. So these are things that you could go in and say to the midwife, look, I'm either able to do this, or I'd appreciate if I could have a bit of practice on this under your guidance. So don't lose that opportunity. An hour and 20 minutes, the list goes on, and before you know it's 4 o'clock, 9 till 4, there's all 5 patients, and with half an hour lunch, and that was that. Okay, after booking in clinic, what I found was antenatal clinic in the hospital setting. So ANC, antenatal clinic. Here again, what you have is patients, ladies coming in, and the situation here is such that the ladies are going to be planning their pregnancy more often than not, or if there is reason for them to have had more scans than usual. So for example, if the patient has gestational diabetes, or if they are polyhydramnios, situation like this, what we do is we scan them more frequently, depending on the level of risk again, or otherwise if there is concern about fetal growth restriction, or if the fetus is small for gestational age, so FGR or SGA. In these situations, we scan the child more, we scan the lady more frequently, and so we're reviewing. It's a constant review, and what we're doing here is, again, we will always do urine dipstick here as well and check their blood pressure, monitoring for signs of development of gestational diabetes and proteinuria, glycosuria, and with the blood pressure, we're just making sure things are under control. Aside from that, like I say, here we also, those patients who are at high risk, there is often quite a significant opportunity here to actually consent the patient for elective C-section. There's a lot of that goes on here, in which situation we also do all the paperwork for the group and save as well. So there's that. Then there was antenatal day unit. So if the mother in the community feels that there is reduced fetal movement, they will call up, and what used to happen in the past is they used to say to the mother, you know what, just go for a walk or have a glass of cold water. That's changed totally. What now happens is the mother is called in, and what they do is they do what we call a CTG, a cardiotocograph. This in essence is a bit like an ECG for the heart. So you get a tracing, except what we do is we get 2 tracing. We get the cardiac tracing for the fetal heart, and we also get a tocography or tocograph. The toco refers to the actual mother's pelvic contractions, so hence a cardiotocograph. So we're monitoring 2 things. This can go up to about an hour. I remember CTG has got a whole set of things that we look for, known as abbreviated the mnemonic as Dr. C. Bravado. So remember, look up Dr. C. Bravado, and then what we'd look at is the CTG has to meet what's known as the Dawes-Redmond criteria. Okay, so look up Dawes-Redmond criteria. and look at ultrasound bravado so that you know what this is about before you go in. But the midwives are absolutely fantastic. Sue in this particular unit was exceptionally helpful and informative in educating you about that. So here you can have, in a CTG, you can have any time up to 40 minutes where the child is asleep, so therefore there's very little movement, after which there's variation. What they do often here also is give the lady a glass of cold water. That kind of wakes up the fetus and gets them moving again as we were expecting, or otherwise they ask the lady to go for a walk as well. Opportunity here, a very rare opportunity in fact, was to have actually observed one of two consultants in the whole hospital who do what we call an ECV, an external cephalic. So basically they move the child. So if the child was in breech position, they actually move the child such that it's head first and turn it around. This is purely done palpation and manually. Usually you can give the lady an injection of terbutaline, which is a tocolytic. But this particular lady didn't. Well, that's the second lady that we saw did. So a rare opportunity sometimes to be able to actually witness that as well. So that's your undo. Great opportunity here also while you're there to be able to actually take case histories here and also palpate. So ladies are usually near term, near full term, near term, and so there's opportunity to actually palpate under the midwives. Use a pinard to listen for fetal heart. And also take a good detailed case history, see how the lady is getting on, and an obstetric history here as well is quite useful. Okay, so we're doing booking, we're doing Andrew, we're doing ANC. What else? So women's health. Okay, women's health clinic, really interesting. You really got to go out there and say hello to the ladies. Extremely helpful, the nurses there as well. I was lucky enough to have actually witnessed a pessary clinic. So pessaries, we're looking at vaginal pessaries, and there are two main types that they use in this particular practice. That's the ring pessary and the gel horn pessary. The gel horn is usually for the older ladies or otherwise those who have a greater prolapse. So the pessaries are here used to actually manage prolapse, not treat. So gel horn pessary, like I say, and there was actually a lady as well with a complete procedentia. But aside from that, gel horn pessary, ring pessary, look at your pessaries, an opportunity with one of the sisters, Sister Mel, who run the clinic. If you're competent enough and if you're safe enough, then you can actually insert a speculum and also a pessary at the same time. So you can do both of these in the one clinic. The second clinic I witnessed here was the Hysteroscopy Clinic under the one of the consultants. Hysteroscopy Clinic, again, extremely useful. There was great opportunity for patients who have come in from the community, referred across by the GP, who have got fibroids or suspected fibroids or polyps. Now, the thing is, they've probably got menorrhagia, dysregulated periods, so dysmenorrhea and irregular periods. Now, the menorrhagia has probably not been controlled through your medications, so you're tranexamic acid, which is an antifibrinolytic. So what they do then is they come in and we're checking to see if there are fibroids or polyps. Excellent opportunity here to, again, speculum, take a cervical biopsy and observe and witness hysteroscopy. The next clinic here was colposcopy under one of the other consultants. So colposcopy, remember, we're looking at the patient has had a smear. Just to remind you, smears start from the age of 25 years of age, every 3 years up to 50, after which it goes to every 5 years up to 64. So that's your hysteroscopy, your smear tests. If there was a positive for the HPV, the human papillomavirus, remember 11 and 16 are the most troublesome ones. They then get referred here to colposcopy. Now in colposcopy, what we do, we put in speculum in, and we actually use some acetic acid. Remember the acetic acid, what it does is it stains abnormal cells. Okay, acetic acid stains abnormal cells. Why? Because abnormal cells don't have a proper cell membrane, so the acetic acid actually enters the cell membrane and it binds to the protein component, which is your genetic material, coagulating that, thus causing the stain. If you're using iodine, then what happens is iodine stains normal cells, not abnormal cells. Okay, so abnormal cells in iodine are not stained. Again, why? Because normal cells have a large store of carbohydrates, i.e. glucose. Iodine tests for starch, so therefore you see the predominant blue black colour. That's the explanation behind them. So colposcopy, you do that. There's also opportunity here to take biopsy both from the ectocervical and endocervical biopsies, as well as actually conducting a full examination and the upper parts of the vagina and the cervical os, in which there were a few interesting things here. So that was that. Women's health, really good opportunity. And then there's the gynecology clinic as well, if you wanted to sit in and learn about some of the conditions and their presenting complaints, taking a history, etc. Early pregnancy unit, M6, this is where Gemma, your PA, is also situated. So early pregnancy unit, again, there are various things that you can see over here, ladies coming in from the community, and you've got an opportunity to take case histories, amongst other things. So there's a whole variety here in the early pregnancy unit, just kind of monitoring patients coming in because they've been referred, if they're unwell or whatever. That was that M1 and 2. Now M1 and 2, that was an interesting area. So there was M1, 2 and M3, 4. What I found useful was that M1, 2 was, I went to M2 and I asked the ladies if there was anyone coming in for a pharyngect. Now pharyngect is your iron infusion. So if you've not done any drugs infusing into the bags, the saline bags, and setting up a full line, then here's a great opportunity. So you've got to cannulate, you've actually got to take obs on the patient, obviously brief history, focus history, obs, and then cannulate the patient, followed by full IV infusion for iron. Ask the midwives to guide you on everything and supervise you, and then after that, of course, again ask them to supervise and have a go if anything. Every single day near enough, well, at least when I was there, every single day, at least one patient came in, if not possibly two. Great opportunity to get that experience in as well. So seize that opportunity. You must go in the morning and say, good morning ladies, is there anybody coming for a pharyngect? And usually they're booked in on the appointments. So that's that. And that was that. And then there was, don't forget, theatre downstairs, so emergency obstetrics, which is where your C-section generally happen in theatre. Again, opportunity to scrub up over here, but then the opportunity to actually witness what's going on. So if you're early enough and you're quick enough, then you can actually see spinal take place as well. So then you can speak to the anaesthetist how that works, the difference between that and an epidural. But aside from that, the actual spinals and what you've got going on there is emergency C-sections or elective C-sections, one or the other, whichever it might be. So that was Obs Gyne. Great opportunity to learn. That's huge. There are loads of departments. I mean, the departments, sorry. There's also the ultrasound, and again, ultrasound, when looking at the babies, that's the midwife to talk you through it. So remember, scanning occurs at 12 weeks and 20 weeks or thereabouts. That's the aim anyway. The 12-week is what we call the dating scan. The 20-week is what we call the fetal anomaly scan. So then we're looking at anomalies. There are just so many components. There's gestation specialist midwife, the diabetes specialist midwife there as well. There's just so many aspects to Obs Gyne. It's what you want to explore and what you want to take from it. So be sure to be very active, proactive, and advocate for your own studies and learns. Go to the nursery, go to the midwives, ask them what's going on, if there's anything interesting going on. Ask them to teach you something. Trust me, you'll be surprised. And then ask them to supervise. If you want to have a go, they're more than happy for you to have a go, as long as you show interest, competence, and a keenness. Be sure to do that. And then, of course, you've got the support from the likes of Mr. Tomlinson and the others, the consultants up there, who will, of course, support that learning. So as long as you're there, you're sensible, you're safe, and you're keen, they're there for you. I hope that was helpful. Be sure to make the most of it at a time, and good luck. Thank you very much.